All right, let's jump right in. We're going to tackle a question that's right at the heart of modern medicine. You've got a new treatment, it's way better than the old one, but it's also a whole lot more expensive. So how in the world do we decide if it's actually worth the price? It's a tough one, pitting our health against our wallets. Let's break down how the experts make these huge, high-stakes decisions.
And look, this is not just some academic question. This is a real dilemma that doctors, hospitals, insurance companies, you name it, they face it every single day. The choices they make impact millions of lives, and yeah, billions of dollars. So how do you even begin to make an objective call when you're facing that kind of trade-off?
Well, it turns out there's a specific tool designed for exactly this situation. It's called Cost Effectiveness Analysis, or CEA for short, and it gives us a structured, logical way to think through these incredibly tough choices.
So what is it, really? At its core, CEA is a pretty straightforward comparison. On one hand, you measure the cost of a treatment in good old-fashioned dollars. But the real magic is how it measures the outcomes. It's not about money. It's about what are called natural health units. And that's just a fancy way of saying the real health improvements that we actually care about. You know, lives saved, infections cured, or even a specific drop in blood pressure.
And this right here is exactly why CEA is the most common kind of economic analysis you'll find anywhere in medical research. Doctors and clinicians are already totally familiar with these units. I mean, they use them in clinical trials every single day. And the huge advantage? You don't have to do the tricky work of trying to put a price tag on a year of life. You just compare the cost directly to the health benefit.
Okay, that all sounds great in theory, but how does it actually work in practice? Let's get our hands dirty and walk through a real-world example to see this thing in action. Okay, so imagine we have 3 different drugs for a gastrointestinal condition. Let's just look at the numbers. Drug A costs $600 a year and gives a patient about 130 symptom-free days. Then you've got drug B. It's cheaper at $400, but it actually provides more symptom-free days. And finally, drug C. A little more expensive than B, but it offers the most symptom-free days of all. So, which one's the best choice here?
So to start, we can do some simple math. For drug A, if you just divide its $600 cost by the 130 symptom-free days it gives you, you find out you're paying about $4.61 for each day of relief. This gives us a solid, concrete number to work with.
But here's where a really clear picture starts to emerge. When we put drug A up against the others, well, both drug B and drug C are cheaper than drug A, and they both give you better outcomes, more symptom-free days, and a higher cure rate. In the world of CAA, getting this kind of clarity is huge. It makes the decision about drug A pretty darn straightforward.
In fact, there's a specific term we use for this. We say drug A is dominated. It's more expensive and it's less effective, so it's off the table. This is a super important first step in any analysis. You just eliminate the obviously bad options. So now, the real and much more interesting choice is between drug B and drug C. One's cheaper, but the other is a little more effective.
To help us visualize these kinds of decisions, economists use this fantastic tool called the Cost Effectiveness Plane. You can think of it like mission control for comparing treatments. It literally maps out every possible scenario.
So the plane is split into 4 quadrants. Let's start with the easiest one, the slam dunk. If a new drug is more effective and costs less than what we're using now, it lands in quadrant 2. This is your clear winner, a total no-brainer. It dominates the old treatment, just like drugs B and C dominated drug A.
The complete opposite of that is quadrant 4. This is where you find treatments that are less effective and more expensive. I mean, this is the worst of both worlds. This option is dominated by the standard treatment, and it's an immediate, easy no.
Okay, now for the tough calls. Quadrant I is where our original question lives. The new treatment works better, but it also costs more. This is the trade-off zone. And here, a decision maker has to ask that tough question, is that extra bit of health benefit actually worth paying all that extra money?
And finally, Quadrant 3 presents the other difficult trade-off. Here, the new option is less effective, but hey, it saves money. So the question flips, are the cost savings big enough to justify accepting a slightly worse health outcome? You can see how both quadrants I and 3 require some real judgment, not just simple math.
So CEA is obviously a really powerful tool, but it's not perfect. Like any tool, to use it the right way, we have to understand its limitations. The important fine print.
Okay, the biggest rule of CEA, the golden rule, really,
is that you have to compare apples to apples. You can only compare treatments that are measured with the same health unit. So, for example, you can totally use CEA to compare two blood pressure drugs that are both measured in millimeters of mercury, but you can't use it to compare one of those drugs to, say, an asthma medication, which is measured in lung capacity. It doesn't work.
Here's another really critical distinction: efficacy versus effectiveness. Efficacy basically asks, can this drug work? And it's measured in a perfect controlled lab setting. But effectiveness asks, does this drug work out in the messy real world with real patients who forget to take their pills? This kind of analysis, pharmacoeconomics, is almost always focused on effectiveness, because that's what really matters.
And one last bit of nuance. What are we actually measuring? Ideally, we're looking at a primary outcome, the final result we really care about, like saving a life or curing a disease. But sometimes that can take years to measure. So often we have to use intermediate outcomes as a stand-in or a proxy, like measuring cholesterol levels to predict heart attacks. The stronger that link is, the more reliable your analysis is going to be.
So with all those tricky trade-offs in the quadrants, you might be thinking, isn't there a way to just get a straight yes or no answer? Well, to get a more definitive bottom line, researchers developed a different approach called incremental net benefit, or INB.
INSIB takes a really bold step that standard CEA tries hard to avoid. It actually puts a monetary value on a health outcome. It does this by figuring out what society is willing to pay for, say, 1 extra year of healthy life. This helps turn that difficult judgment call of CEA into a much more straightforward calculation.
Here's the gist of how it works. First, you set a willingness to pay threshold. That's what that Greek letter lambda stands for. Then you just plug it into a simple formula. You multiply that lambda value by the extra health benefit you get, and then you subtract the extra cost. That final number tells you everything you need to know.
And the real appeal of INB is its beautiful simplicity. If that final number is positive, greater than 0, the treatment is considered cost-effective. If it's negative, it's not. Simple as that. It just cuts through the ambiguity by creating a clear financial bottom line.
Okay, so let's wrap this all up. Cost-effectiveness analysis is the go-to tool for comparing treatments based on their costs and their real-world health benefits. It's practical, it's widely used, and that cost-effectiveness plane is an awesome visual for understanding the trade-offs. But it's crucial to remember its limitations. You gotta compare apples to apples. And remember that methods like INB can give you a clearer answer, but only if you're willing to take that controversial step of putting a price on health itself.
And that really leaves us with the ultimate question, doesn't it? When we decide if a new medicine is worth the cost, what we're really asking is this: how much is 1 year of healthy life worth? To you? To society? There's no easy answer to that, but it's a question every single one of us has a stake in. Thanks so much for tuning in.